Thank you, Dr. Shivam, and the esteemed panelists for the kind words of introduction. Good afternoon, everyone. I'm delighted to be here today to discuss about the newer concepts in the management of osteoporosis. As we all know that osteoporosis is a disease of bone, where we have decline in the bone mass, there is alteration in the microarchitecture, which leads to increase in the bone fragility, makes the bone more prone for fracture. And it is basically a major public health concern for postmenopausal women and elderly males. Traditionally, and in fact till date, we are managing osteoporosis with only one drug, that is bisphosphonates, with addition to the calcium and vitamin D. So why we need these new molecules? What is the concept behind this newer therapeutics? So we see that despite having compliance to the bisphosphonates, to the calcium and vitamin Ds, we see that there are history of recurrent fractures again and again. So to address these unmet needs, we need some better therapies which will have better efficacy with lesser side effects. So with this introduction, this is a slide which shows the first, the upper half, the traditional approach which we are following, and the lower half which shows the current treatment regime. So if we start with the bone resorption inhibitors, that is the anti-resorptive molecules, these drugs decreases or slows down the bone mass loss, but with slight improvement in the bone mass, but they do not improve the bone microarchitecture, and their action is very slow, that is over a period of 3 to 6 years. And then if we add the anabolic therapy, the bone microarchitecture which has been lost previously, it cannot be recovered, but the bone mass density can be preserved or can be improved a little bit if we add the anabolic therapy after the anti-resorptive therapy. So overall, in this approach, from anti-resorptive to the anabolic therapy, we are not able to improve the bone microarchitecture. On the other hand, the current treatment regime, it suggests, the studies have shown that if you start with the anabolic therapy, so this anabolic therapy, what does it do? It improves the bone mass, it also improves the microarchitecture over a period of 1 to 2 years. So it is rapidly acting, it improves the bone mass, and it also improves the bone microarchitecture. But as we cannot give the anabolic therapy for a long run, for about like after 1 or 2 years, we need to add anti-resorptive to preserve the bone mass which have been already added up by the anabolic therapy. So this treatment regime is better, where we first start with the anabolic therapy followed by the anti-resorptive therapy. So what are the novel agents in both these groups? First, the new osteoanabolic regime or new osteoanabolic therapy includes the sclerostin inhibitors, and then there are some newer drugs which can act on the DPP-1 pathway, and the newer anti-resorptive drugs include the one which acts on the RANK ligands, cathepsin K inhibitors, and the SRC kinase inhibitor. So we'll discuss about these molecules in detail one by one. So let's first start with the osteoanabolic therapy, that is the anti-sclerostin antibody. So what is this sclerostin pathway? To understand the drug, how does it act, we need to understand what is the normal physiologic pathway. So this WND signaling pathway, as you can see in the basal condition, can I have the pointer here so that I can? So this is the WND protein pathway. In this signaling pathway, the WND binds to the LRP56 result co-receptor, and it prevents the phosphorylation of the beta-catenin. So once the beta-catenin remains unphosphorylated, its levels remains high in the cytoplasm, which further translocates in the nucleus and leads to increase in the gene expression. That is, it promotes the unphosphorylated beta-catenin, promotes the osteoblast or the bone formation. On the other hand, when the sclerostin binds to this WND signaling pathway, it inhibits the action of the WND and it inhibits the formation of the bone. So it increases the beta-catenin phosphorylation, and hence the further gene expression is inhibited. So if by some or the other way, if we can inhibit this sclerostin enzyme, if we can inhibit this sclerostin protein, we can probably stimulate the bone formation. So how this sclerostin is secreted? Under some mechanical unloading or under bone stress, in the presence of estrogen deficiency, osteocyte secretes this sclerostin protein, and this sclerostin, it inhibits the differentiation of the stem cell to the osteoblast, and it also stimulates the rank ligand, which is a stimulus for increase in the osteoclastogenesis. And how the sclerostin is produced? It is a product of the SOC gene, which inhibits the osteoblastogenesis as discussed. And if there is some mutation in this gene, then it leads to increase in the osteoblast or increase in the bone formation, and this condition is called as Van Buchen disease, where there is increase in the sclerosis. And this mutation has also been seen in several kinds of skeletal dysplasia, and this forms the treatment target for osteoporosis. So, as I said, if we inhibit this sclerostin by some antibody, then we can promote the osteoblastogenesis. And we have this drug called romosozumab, which is available in the name of Evenity. It is a sclerostin inhibitor. It is a human monoclonal antibody, and it is used for a duration of about 1 year. And this indication remains for severe osteoporosis. So, if after 1 year of the sclerostin antibody use, if we want further anti-osteoporotic drug, then we need to switch to anti-resorptive therapy. The recommended dose is 200 mg. It is given subcutaneously once every month for 12 doses. It is administered by a healthcare provider along with the use of calcium and vitamin D supplementation during the treatment phase. It has received a black box warning that it is contraindicated in patients with a history of MI or any other cardiovascular disease within the past years. As it was seen in this ARCH trial, that this drug leads to increase in the cardiovascular events. However, in some other trials like FRAME trial, these events were not supported, but still it has received the black box warnings that it should not be used in patients who have got a history of cardiovascular events. There are some other safety concerns that it can cause hypocalcemia, it can cause osteonecrosis of jaw and AFF, that is atypical femur fracture. Now, the clinical studies have shown that even with a single dose, it can improve the bone densitometry at the level of spine as well as at the level of hip. As you can see here, these are the different doses of romosozumab given, and were compared to the placebo therapy, and to see that there was significant increase in the BMD at both the level of spine and at the level of hip at the different doses. And this was supported by improvement in the bone turnover markers. In the romosozumab group, there was increase in the bone formation marker, that is a P1NP, osteocalcin and BAL, and there was a decrease in the CDX, which is a bone resorption marker, compared to the placebo. Now, this is a very interesting data which shows the comparison between the romosozumab, alendronate and teriparatide. As you can see here, the green line demonstrates the romosozumab arm, and this orange one is a teriparatide arm, and this one is the alendronate arm. This is a placebo arm. So, if you can see that there is a significant increase in the BMD by around 11% in the romosozumab arm, while there was around 6% and 2% with teriparatide and alendronate in the level of spine. At the level of hip, again there is a significant increase in the BMD in the romosozumab arm. However, in the alendronate and teriparatide arm, there was a lesser increase in the BMD, while at the level of neck, the increase in the BMD was similar in both alendronate and teriparatide. So overall, we can see that there is a huge increase in the BMD with the use of romosozumab over alendronate and teriparatide. And this is because of the changes in the bone turnover marker. If you see clearly over here, with the use of romosozumab, there is certain increase in the P1NP, that is the bone formation marker, and as well as there is decrease in the bone resorption marker, and that's how romosozumab leads to increase in the aerial as well as the volumetric BMD. And if we see the bone turnover changes in the BTM by teriparatide, the increase in the bone formation marker starts rising after 3 months of the therapy, while with the romosozumab it is immediately after the start of the therapy. As well as with teriparatide, there is also increase in the bone resorption marker, and that's how the efficacy of the teriparatide is less compared to the romosozumab. And when we compare this alendronate, there is suppression of the bone resorption marker by alendronate, but there is also suppression of the bone formation marker, and that's how alendronate